Hello, Happy New Year, and welcome to the Massage Matters podcast with the Massage Collective. It's me, Matt Scarsbrook, Anna Maria Mazzieri, and Becky DeMott-Horton, and this week we are gathered around the microphones in our proverbial studio with none other than Eric Purves. For those of you who haven't met Eric Purves before, he is a registered massage therapist from Vancouver Island in Canada and a huge advocate of evidence-based practice in manual therapy. His specific areas of interest is chronic pain, and as well as working with clients, he has a fantastic series of courses which is focused on introducing pain science into clinical practice. And that's largely what we're going to be touching on today. But before we kick off, I just wanted to read a couple of short excerpts from a blog post on Eric's website. Now, this is from October 2020 and is actually written by a guest writer, Crystal Lecoeur, who works with Eric. But I think it speaks to Eric's ethos very, very well. So, Crystal writes, "It's true that evidence-informed practice means we need to come to terms with the fact that the stories we've believed, the very foundations we've built our entire, often very successful practices on, were simply untrue. Massage therapy does not improve our patients' general circulation, reduce cortisol levels, or even have positive, measurable effect on delayed onset muscle soreness. Massage therapy cannot change fascia or your patient's connective tissue, even if you work deeper. On that note, it turns out that with deep tissue treatment, you're not actually affecting deeper tissues at all." But it continues, "Understand that the positive tactile input you offer as a manual therapist has value, no matter what techniques or modalities you prefer to use. Your techniques still work. What you do still matters. You still have value. It's just the stories that need to go." Which I think perfectly sums up Eric's approach, quite frankly, which is that massage therapy is a wonderful thing, but we really do need to be working harder on integrating the evidence into our practice. So sit back, enjoy the next hour or so, and I'll see you on the far side.
So Eric, thank you so much for joining us today. If anybody hasn't come across you before, do you want to just give us a quick introduction about yourself and what you do?
Sure. Yeah. Thanks, guys, for having me. This is really exciting. I'm glad that we found each other. It's nice to have some colleagues on the other side of the world. So which is great. I see Anna Maria's having a drink, and it's a bit early here where I am, but 8-hour time difference doesn't make drinking at this time of day socially acceptable.
In lockdown, it's
Yeah.
socially acceptable.
Particularly, I have to go pick up my kids from school in a few hours, so that wouldn't go well.
Yeah, that's always a bit embarrassing.
Yeah. Yeah. So thanks, Becky. My name is Eric Purves. I'm a registered massage therapist who lives in Victoria, BC. And for those who don't know where that is, we're on Vancouver Island on the very southern tip on the far west coast of North America. I've been practicing as a massage therapist since 2006, the beginning of 2006. I have had a clinical practice. I own a clinic in town, which I've had for about 15 years. For about the last 5 or 6 years, I've decided that there's a lot of stuff that I didn't know and things weren't making sense. So I went on this kind of rabbit hole journey to try to understand why my patients made no sense to me. Particularly those people that were in a lot of pain and they weren't getting better. And so I ended up, I have a teaching contract with an organization here called Pain BC, where I teach a course specific to massage therapists on chronic pain to try and help them understand and do hopefully a little bit better with that population. I also do other content stuff as well. I have my own teaching company, my own kind of professional education company where I have been teaching. I think I probably did my first one of those probably about 2016, something like that. Early 2016, I think. I started teaching my first content courses with them. And basically what I was trying to do is just get the evidence, particularly about pain, and the limitations and powers of manual and movement therapy, to help people. And I found that back then I was all alone. There wasn't really a lot of people out there to really that had any idea what I was talking about. I was kind of seen as some, how would you describe it? I was seen as being a bit of a heretic, I guess. And people were thought I was crazy, and they thought I had found some other cult, and because I was really starting to challenge a lot of what people thought and what they learned and what they did, and yeah, and it wasn't until the San Diego Pain Summit that I went to in 2015, the first ever pain summit, that I realized that I found my people, because there was a whole other community of other therapists, not as many as you would like to think back then, that were asking the same questions and trying to get the same answers. And that is where it has led me to where I am today. That was a long answer to introduce me, but
No,
anyway, that's kind of
perfect.
a quick synopsis of my story.
No, that's
I have
perfect.
to jump on and say I love the idea that patients don't make sense, and as a reason to look further. I love that. And if I'm right in thinking, you've got a background in psychology, right? In terms of your original studies, and it was part of what you'd studied originally, and then your training to become a massage therapist, that you were seeing a lack of correlation, shall we say?
Yeah, that's true. Yeah, so I did my undergrad. I graduated from the local university here back in 2001. Which, when I was thinking, I just said that, it makes me feel like, God, that was 20 years ago now. It's like,
Oh, it's scary, isn't it? Like,
yeah,
anything with a 2 on the front should be really recent, but it's
yeah.
not.
So yeah, in 2001, I did my degree at the university in psychology. My area of focus for that was really, I was looking at, like, I was interested in the biological aspect of psychology, so the brain and the nervous system, and how that was responsible for behavior. And so we did all kinds of courses on sensation and perception, and how these things, learning, and how these things were influenced behavior. And then when I went to massage school a couple years after that, what I found was, we talked about the nervous system, we talked about the brain, but it was this very linear kind of, like, this is what happens, and there's a sensation here, and this is what happens, and this is where it goes. And it was very, like, it was very general, and it didn't really explain, like, why people hurt, because all the stuff we learned about why people hurt always was focused on, like, we had courses on fascia, or orthopedics, or like all biomechanical stuff, or trigger points, or it was all these tissue based things. And I remember at the time, I remember having a conversation with a colleague at one time in massage school, being, I don't know, this doesn't really make a lot of sense, but I guess I just accepted it, because I paid all this money. I'd been in school, here it's a 3-year diploma program here. So you kind of you're in it for a long time. You just keep on getting inundated with the same information. So I think I just kind of accepted that was okay. Like, oh, I guess pain, there's the nervous system, but pain has all the stuff to do with the tissue, and the nervous system kind of matters, but not really. And what I found was, after a number of years in practice, once I had kind of done all these corrections, I had found all these dysfunctions, and my palpation skills were like next level Jedi. And I was like, I could do all this stuff. And that's how I felt, because that's how we were educated, and all the content courses I had taken had really emphasized these, like, supernatural abilities that we had. And, but what I was finding is that when I applied these to certain patients, some of them got better and some of them didn't. Some people got worse, and some people, nothing happened to them. And so it wasn't until, and then, I think I told you guys this before, is that my first office I worked at, we had a pain specialist who was right next door to us. And he was injecting people with, lidocaine and saline injections into trigger points. And, he was doing spinal injections and all kinds of stuff. And he would do these things to people that hurt a lot, but they never got better, because they would go get treated from him. They would come see us. And so there's a lot of things that just didn't add up. And it wasn't, and so I started asking a lot of questions and I wasn't getting any answers. And then somehow, somewhere along the line, I don't know where it came from, but I wish I knew, I found Explain Pain. And I sat down and I read that book in a day and I thought, oh, this makes way more sense. This is putting all the pieces of the puzzle together, because I had this like the psychology stuff, the sensation, the perception, the nervous system, the brain, and then there's all this biomedical stuff, but there wasn't anything that really connected the dots. And it wasn't until I read that book that things started to make more sense. And I don't know if I would have been able to make sense of that as quick as I did if it wasn't for that kind of psych background about understanding, well, there's a human here with their own things, and then there's tissue, but the human matters more than the tissue. Anyway, so
I love the positiveness, though, that change of paradigm for you, that all of a sudden, instead of going through a cognitive dissonance, all of a sudden you thought, this is actually making sense. Finally making sense, instead of, oh my God, everything I was taught, it was not right, or I was taught old beliefs. Actually, for you was much more of a positive awareness, that all of a sudden you realized that's what it is. I love that positive. We need that because too many people are feeling very uncomfortable because obviously they've been taught unhelpful beliefs and non-correct beliefs, and they are a little bit stuck into that, unfortunately, in a very negative way. So your positiveness is refreshing.
Oh, well, thank you, Anna Maria. Yeah, I went through that. Like I kind of skipped out my morning part there where I thought, oh my God, what am I doing? But it was a quick turnaround. And then once I realized that everything that we do matters and it's important, it just works differently. That made it a lot easier to kind of reconcile the internal conflict I was having in my brain. So it didn't impact really, I think, what I do with patients, but it impacted kind of how I understood, and my expectations from myself and from them. And it definitely impacted a lot of how I explained things.
Yeah, they started making a bit more sense then.
Yeah, for sure. Yeah, it made a lot more sense.
Was there a time at all, Eric, when you started to discover that and you read Explain Pain, that you questioned what we do as massage or manual therapists? Or was it always for you just the way you gave an explanation around that? Was there ever a time where you went, oh, we shouldn't be using manual skills at all?
No, I never. I never felt that we shouldn't use manual skills. Because that's how I was making my living. So I was like, no, I need to figure out how to put these together. I say, because we have an entire industry here, and in where I am in BC, massage is a huge industry. Like we have, I don't know, over 5,200 therapists registered
Wow.
here. And anybody, if you want, like you can make a good living doing it, and there's a lot of demand for it. So I never felt like what we're doing is useless. I never felt like what we were doing didn't have value. I think early days when I was trying to educate people and trying to communicate about this, I think a lot of people heard that you're stupid, you're terrible, stop doing what you're doing. But that was never my intent. But that's oftentimes, as we know, that's how this stuff can come out, is that you don't know what you're doing. But I always felt that, no, I just needed to reconcile how to put these together, because I knew that touch was powerful. And I knew that we had a whole industry of people that needed it. Yeah. And thrived on it.
Do you think you make the point that up until you went to the San Diego Pain Summit, you kind of felt quite alone with this, and when you tried to communicate it to people, you were looked at like you had two heads. But what do you think do you think it is that fear around you're being told you're being stupid or you're doing something wrong that causes that resistance to embracing this stuff? Or what is it that for you it obviously made sense, and like Anna Maria says, it was a really positive experience, but other therapists don't have that quite the same way? What do you think it is, that threat to who they are and what they do, that causes that?
Yeah, I totally think so, Becky. I think it's a good question, because I think what happens is people identify with their type of therapy or their preferred narrative. And I think when you challenge that, what I see anyway, in my experience, is a lot of people feel that challenge invalidates them, who they are as a therapist. So I think that it's people get scared because they don't really know. Well, if I am a craniosacral therapist, and now you're saying that craniosacral therapy isn't doing what I think it's doing, even though you may give them the message that what you're doing obviously has helped people for decades, but maybe it's working through a completely different mechanism. Actually, well, it is working through a completely different mechanism, because we know craniosacral doesn't do what it's supposed to do. Let's not say maybe, let's be sure. It's working through a completely different mechanism. Well, that person will often hear, and they'll think, well, you're telling me that what I do as a therapist is useless. And I had a conversation offline with somebody about this relatively recently. And I said, no. We're not saying we're doing it as useless. We're saying it's working for a very different reason. But you have to realize that the explanation or the belief you have around what you think you are doing doesn't stand up to science. And in a lot of cases, we always have to be careful that explanation might actually be harmful to that person.
Yeah.
It might lead to disability or dependence, or maybe even more pain, if depending on how that person internalizes your intervention.
And that for me, Eric, is a very, very important point, because we hear so many therapists when we're having those discussions that they say, well, does it really matter? My client feels better after they see me. But the feeling better is not the desired outcome. It might be a temporary symptom modification, symptom relief. But if for them to feel better, you have used language, or you used an intervention which takes away self-efficacy, then that has a nocebo effect. Then you might have made the person feel better in terms of pain, but on a long term, you have instilled a notion of dependency, and that we know that is very, very dangerous. So it's really important that the message comes through to the therapists, so that just because they feel better after they leave your room, that is not the be and end of a treatment.
Yeah, 100%. I don't have much more to add on that. I agree 100%. I think the only thing I like to emphasize, and I think I like to use the nocebo, is that what I would really think is what's really important is, if you understand the contextual effects, you understand the placebo-nocebo research, then it really makes a lot of sense why our stories and our own beliefs matter. And I think that's one thing that might be missing in a lot of people just don't have that base of knowledge. So when you're telling them why it's important to change your story, well, why does it matter? My patient feels better, but there is this other stuff underlying that may work against you in the long run.
There's a couple of thoughts that I'm probably still trying to form as we're talking now, but have come around in part due to a post a good friend of ours put up recently on their blog, Massage Moose. Go and read that blog. But is it, if we're talking about the potential for nocebo and the potential for people to get very tied in with identifying with who they are, with the type of technique they provide, there is also obviously a link for the client to identify with the type of treatment they receive and the type of treatment they seek out, which speaks to that point you made a few moments ago about reliance on the therapist and losing self-efficacy, etc. Now, obviously, one thing that we are sort of doing is introducing evidence-based practice into these modalities that have been around for a long time. They've had explanations that are now fairly well debunked in a lot of cases, and very biologically questionable in many others. But we can explain some of the positive outcomes, perhaps through a more evidence-based lens, particularly when we start talking about the power of touch and the power of actually just spending time and talking to that individual. But is there maybe an argument that we should perhaps start just ditching some of these modalities and just throwing them out and going, yes, you've seen some positive outcomes through using the modality, but the risk that the modality per se will still lead to misleading other therapists and will still lead to misleading your clients about exactly what's going on isn't worth hanging on to those modalities, and we need to throw them out and maybe just start again from the evidence base. Does that make sense as a question?
Yes, it was kind of more of a statement, I think, which I agree with.
Okay.
Yeah, there was a question there. So, do you think it's good to throw away some of the modalities? That was kind of the question, right, Matt?
I think so. Yeah, yeah. As opposed to just shoehorning them into the evidence base a bit more loosely.
Yeah, no, and I think that's great because otherwise what we try to do is you try and shove a modality into an evidence-based framework and that modality is just completely out there, right? Yeah, I think there, I mean, without going and naming a bunch of modalities that are absolute garbage, then yeah, yeah. I'm trying to think of the least offensive way to say that. I think there's a lot of them that we could just toss out because there's no use for them. Because you can't put it into an evidence-based framework if the entire basis of that modality is to try to do something that is completely biologically implausible.
Yeah, so
that's my thoughts on that.
Yeah, and I think from that you kind of, I guess it comes back to by explaining the mechanisms of what we actually think is going on. It does, in a way, advise what you do with your hands, doesn't it? And it kind of brings us on to when we were talking before. You've got that brilliant acronym of TPN,
Yeah.
which I think. Do you want to expand on that a little bit, because I think that's a great concept.
Yeah, it's funny. I think that acronym came up one weekend. I was teaching in a course, and we were having drinks after a course one time, and we were all kind of going off about how every single modality has like an acronym. Right?
Yeah.
You put 3 letters together, it's a good sell. If you have 4 letters, that's like next level stuff, right?
That's advanced.
Yeah, it's advanced, right? So we're like, well, and so I came up with TPN, which was basically just touch people nicely.
Nice. I love that.
Right. And then we'll make that into a 7-level certification system where you got to recertify every couple of years and pay a couple $1,000s or pounds to, we'll travel the world and we'll get other people to join us and they'll be like affiliate teachers. And yeah, we went to this big thing. So anyway, yeah, TPN, I think if you're looking at manual therapy, that should be the goal of it. And how you TPN somebody is kind of unique to you as your own self as a therapist.
Have you just verbed an acronym?
Yeah. Has that ever been done before? I don't know.
Yeah, I'm going to TPN you.
Yeah. Yeah. So that's what I use all the time.
Yeah, I like that, and I think it does speak to that kind of, we've spoken about it before, being maybe having less specificity around our techniques and actually just, like you say, just providing a pleasant touch experience. And you say it's individual to the therapist, but it's also individual to that client, isn't it? Because what Anna might find pleasant touch, maybe you don't. Everybody's slightly different in what they feel, and so it's kind of one thing I've kind of tried to say to people is try and get away from, if somebody presents with a sore shoulder, these are the techniques you should do. Actually, who is that person presenting to you? What do they find a helpful experience? And those are the techniques that you should use, because they tap into that person rather than necessarily be this really structured framework that for X you do Y.
Yeah, I think that's a great point, Becky, and I agree, because I think if we only identify ourselves as a certain type of therapist that practices in a very specific framework, then what we're doing is we're putting our expectations, our beliefs, our wants and desires onto the patient, rather than the patient, the one being the lead, who says, "I got a sore shoulder. This is what I'm expecting from treatment. This is why I'm coming to see you, and I can't. It's impacting my ability to, I don't know, do whatever." then I think then you as a therapist have to say, okay, well, how can I meet this patient's needs rather than me putting my needs on the patient? So it's kind of flipping that script, I think, is really, really important.
And I suppose, getting into the kind of the core, I suppose, of the conversation that we were going to have today, which is the linear cause and effect model is just really, really comfortable. It kind of, something about it that just seems to make sense. And definitely it's very easy to understand and to grasp from, as you're learning to begin with. And the more experienced you get, the harder it is, I think, to move away from it. But obviously your area of expertise is effectively teaching how to integrate evidence-based practice or biopsychosocial models into current practice, into current clinical practice. So do you want to talk a little bit about how you might go about doing that? How does one go from this kind of linear cause and effect to actually starting to apply some of the evidence-based or BPS models into their clinical practice?
Yeah, it's not easy. It's the first thing I always say you have, if you want to adopt an evidence-based practice, if you want to adopt, if you want to adopt like a conceptual framework like a biopsychosocial, which is where my bias is, that's how I think is the best way of dealing with these, of treating and of educating, is you have to be comfortable in uncertainty. Yeah. You have, if you are certain, like you are in a linear cause and effect, you see back pain, you do your assessments, so you find this dysfunction, and then you do this very specific treatment. That's this like very linear thing, and we know that humans aren't linear, right? We know that stuff doesn't work all the time. So the biggest thing I focus on is on being uncertain. And so anyone that'll take a course from me, I want them to be comfortable in not having all the answers, because we don't have the answers. All we can do is have a bunch of hopefully less wrong choices. And that's the big thing. And, when I did my, after the first San Diego Pain Summit, I got home and I put my application into the University of British Columbia to do a graduate degree, because I was like, I need to know everything there is to know, and I need to understand the research, and I need to be a leader in this profession, because I'm not going to sit back any longer. And so what I ended up doing that for the 3 years of my graduate degree is that's what I did. I looked at evidence-based practice and biopsychosocial and all these kind of like buzzwords, right? Pain science, choose all these keywords that everyone uses around. But basically, what's the research evidence around treating humans? And I focused on how do we do that and how do we apply that to practice. And so I read basically anything that I could ever find that was published or written on these subjects. And my interpretation of the research evidence for how do we do this, how do we apply it? So the first one, like I said, you have to be comfortable in being uncertain because we don't have the answers. The other ones would be basically is be a good listener and validate the patient's pain experience. Because when we look at the qualitative data for certain on people that are in a lot of pain, they don't ever feel listened or heard. They feel invalidated. And if I'm sure you guys, you know of the people that are advocates for the patient experience, right? Like Gilletta and Keith. And
absolutely. Well, Gilletta was on the pub recently.
Right.
Week, although that's not relevant to how we're recording this podcast. Gilletta was on the pub recently. And feeling listened to was, it was number one, wasn't it?
Yeah, and that seems to be the thing that keeps on coming up, not in just the patient experience, but also in the literature as well, is that, so listen, validate. I think the other thing too is, touch in a way, like, so interact with the person in a way, so put your hands on the person in a way that you are comfortable and confident in, and that the patient is comfortable and confident in, right? So it's kind of having that kind of, okay, what are your expectations from this? Right. So you've responded well to this type of treatment. Okay, well, maybe I'll just try and do that type of treatment again to see if it helps. Because we know that the best predictor of, future success is past success, or future failures is past failures. So I think that's really valuable to understand as well. And the other big thing too is basically just giving people permission, right? Permission to engage in life, permission for people to move in ways that they want to do the things that they want to do.
Permission or reassurance?
Yeah.
I'm a bit funny with words, and I struggle when they use that often in. There are the word permission, giving them permission to be active. I struggle with that because, again, it puts us in a hierarchy, us
Right.
as therapy in a hierarchy, higher up than the
Yeah.
client. And I like to use more reassurance
Yeah.
because it's actually, it's us to say to them, yeah, you know what, it's okay, you know, it's positive, it is not going to be, you know, that bad as you think, instead
Yeah.
of just say, you know, you can do that. And I think therapists with the words can already build self-efficacy by using particular words more than others. That's very personal to me. I have a bugbear with certain words.
Yeah, no, and that's a good point, Anna Marie. I think, yeah. So I guess to rewind that is, I guess the way I would say would be to use reassurance to educate your patient.
Yeah.
Right. This all comes from, I think, Gifford's
Yes.
papers and stuff. Like, use reassurance to educate your patient, and then through that, you are maybe not saying go do this thing, but you are then kind of inferring.
Yeah. Encouraging.
You're encouraging them to, rather than saying do this.
You can do this.
We're not just patriarchal, kind of like, you know, we're supportive, right?
Although you can see, or I can see perhaps, times when almost giving permission is possibly the right term to use, where a client perhaps being told, you should never do deadlifts, you should never bend over with your back, you should always bend your knees and keep your back straight, and also, you know, almost, sorry, there is an element of reassurance, I suppose, that actually that thing is safe, but I suppose sometimes it does need to be stronger and almost hit that permission level to sort of say, you know, what you have been told, unfortunately, is perhaps not what we know now, or not the best thing for you in your current situation, because of course you never want to badmouth other therapists. But I think having it come with a level of confidence in what you're saying also helps. I think sometimes we can skirt issues and be a little bit too what's the word I'm looking for, or almost not direct enough sometimes with our clients. And I think there are occasions where actually being a bit more direct with someone can be beneficial. Just to pick up on Anna Maria being fussy with words.
Well, I think that's a good point, though, too. I mean, these are good conversations to have. I think they're really important, because this goes back to the first thing, right? Which is like meeting the patient, right? So treating the patient, like meeting them where they're at.
Yeah,
does that person that in front of you, are they the kind of person that's like, just tell me what to do, and they want permission, or is another person that you need to kind of encourage them and reassure them, you know? So yeah, so it's never like anything, right? It's being comfortable and being uncertain.
Yeah.
Right. So we can't say this is what you do. We're like, do this, or maybe do this, and see what works best for that person in front of you.
And it always has to come. It always has to be collaborative. It always has to come from them. Our role is just to formulate a question so that they themselves make that choice. Because, and that's where, Matt, in this sense, I slightly polite and respectfully disagree, because actually, I don't think should be the role of the therapist to say, you can do that. It's the client that needs to feel so comfortable and confident that they say, I can do that. And you can say, yes, you know what? You can. You can. I again, it's different, you know, different way we approach it. I got this thing about words, and sometimes words create stereotypes. You know, stereotypes even in terms of relationships.
Absolutely, and you know, I think what this illustrates, or you know, this sort of this conversation around the different words that we use, is perhaps, yes, we need to be making the client feel comfortable enough to be able to explore a whole range of different movements themselves and understand why their biomechanics is less important than they perhaps have been led to believe previously when it comes to their pain experience, in whatever works for them, however the interaction works. But I think also probably a really nice important takeaway is that it should allow the therapist to feel totally free to engage in the client in literally any way, and that there is no, back to a point you made earlier, Eric, there is no set of instructions about how a therapist needs to get a client moving. You can use any movement, any prop, any circumstance in order to get the client moving in a meaningful way for them. Is there such thing as a corrective exercise? It suggests that the exercise itself is correct. I don't know, but I think what you're saying there, Eric, speaks to that, right?
Yeah, I think so. I don't think there's a right or wrong way of doing things. I think there's just there's options, right? And I think this goes back to, like I said, we have to be comfortable and not having all the answers. And I think it's good to have a variety of kind of skill and knowledge sets for things about, different ways of touching, different ways of moving, different ways of, prescribing exercise, or, or giving advice. Like we should have a general knowledge of that stuff, and just try and find what we're comfortable with and what the patient is comfortable with. And like I find that for me, in all the years I've been involved in this, that I find in clinical practice that it's actually easier now than it ever was before, because I'm just kind of, I don't really hold too strongly onto any one specific way of doing things. I just am kind of, okay, well, what can I do for you today, and what is it you're looking for, and then I can kind of meet them where they're at, and rather than everybody that comes in, I have to assess them for a sacral torsion if they've got low back pain, and I got to follow the whole MET protocol, which for some people they've had that done before and it works for them. And you're like, I could throw some of that stuff in there just to kind of gain their confidence, maybe just to get them to do something. But I'm not going to follow that whole narrative, and I'm not going to follow that entire protocol. But I'll kind of take a little bit of pieces of all the stuff that
with the right narrative.
Yeah, and kind of put it into my TPN framework. And I feel as long as the person doesn't feel they need me anymore, then if I can try and put myself out of a job every day that I go to work, then I feel like I've done my job. And that can be scary to a lot of people, I think.
Yeah, sure.
As a business model, it sounds absolutely terrible, doesn't it?
Yeah. Go away and never come back unless you're really desperate. Yeah, I know. But it works though. And I think when you're first starting practice, I want people to come back and see me every week forever. But after you've been around for a while, I think you start to realize that, no, I don't really want that. I want people to come in, and I want to feel like I can facilitate them and, give them some more, maybe encourage some self-management stuff. And the term that Keith Meldrum introduced to me a couple of weeks ago, I did an interview with him. He used the term supportive self-management, which I really liked. Nice. It was just kind of that extra word, supportive, in front of self-management. I thought that's great, because you guys know Keith, right? So as someone who's been in chronic pain for a long time, he still goes to get massage, and he still does his stuff, because he uses them as part of his self-management strategies.
But he chooses to. That's the difference. He chooses to do so, not because he feels that he needs to, or because the therapist told him. That is the big difference.
Yeah.
That's why maintenance treatment shouldn't be called maintenance.
No.
People can certainly come regularly, but why they want to come regularly must be different.
Yeah, I'm glad you brought that up, because that's super key, right? Because we're never saying don't come back and see us ever, right? We're not saying we don't like you, but come back when you feel like this is part of something that you need to do for your own health and well-being. Don't come back because you feel if you don't come back on a regular basis that you're going to be at more increase of injury, or your muscles are going to stop supporting your body, or these other weird stories that people get given or have. That's where it becomes the expectation is.
Come back because you enjoy it.
Yeah, come back because it feels good.
Yeah, because it feels good. Feeling good is underrated.
It's underrated, yeah.
Yeah.
a bit of a catchphrase. No, I think if we're going to talk about words, I think the thing with maintenance, it's a classic biomechanical, or even ditch the bio. It's a classic mechanical
Yeah.
that somewhere something's wearing out, needs in some way fixing, replacing, repairing, in order for you to continue. And that's just not the case. Our bodies are amazing at doing this themselves. And for me, yeah, massage should be as much as anything because you enjoy it, and it's exactly as you say, Eric, because it's part of my well-being.
Yeah, feels good.
As opposed because something's going to fall off if I don't.
Yeah. Yeah. Oh, I didn't get a massage. My arm fell off.
Yeah.
Said no one ever.
Yeah. Yeah. Exactly.
But I think it's really nice as well. Because sorry, Anna, go on.
No, you go.
Well, there's a couple of points there, but I think overall, what picking out a couple of things you said there, it just leads to a much more open, honest, collaborative relationship with your client. The fact that you're not giving them this narrative that they have to come back and see you or they're going to fall apart. And also the fact that you're being open and honest about your uncertainty. I love quite often I'll have a conversation when I see a client for the first time and they've presented with whatever. And, you have that conversation about this isn't an exact science. So we're going to try some stuff that may or may not work for you, but you need to communicate with me so that we can find the right path here. And all of a sudden you've broken down that barrier of, oh, well, I've just got to lie here and let her do this, even though I'm not enjoying it at all, because that's what's going to fix me. You really get into that collaborative relationship, which comes back to what you said a little bit earlier on. It's a far nicer, easier way to be a therapist.
Oh yeah, way easier. Yeah.
Than sat there thinking, oh my God, I've got to fix this person, and I've got to be the one that's got all the answers. Actually, let's work together. And if you're not enjoying something or it's just not working for you, tell me, and we'll figure something else out. I think that's really nice.
It's liberating.
I think so.
Yeah,
I think so.
I think touching on the point you made, Eric, about having I'm going to use the word toolbox, but actually no, I'm not going to use the word toolbox, because toolbox again suggests mechanical.
Yeah.
We need a different word for toolbox. A range of different skill sets within kind of health and well-being space in order to facilitate people getting moving again. I think picking up on what Becky was talking about there, if you have sort of that range of skill sets, and one of the things that you can do with your client early on is set goals.
Yeah.
And then essentially say, what do you want in order for us to be able to help you achieve that goal in terms of the modality? What modality is going to suit you best in order for you to achieve the outcome that we're looking for? Now, the outcome we're looking for will involve you moving and activities of daily living or lifting stuff, or it's going to involve you using your body by yourself. But what modality works for you in order to get there? And hey, if you've never had treatment before, let's try a few and see which works best, and not think too much about why one works better than the other. Just take it that it does, and for you, and then build on it.
Yeah, I think that's important. And the one message I always give to clients, and I'd say this in the courses I teach too, is that if someone comes to see you for 1 hour in a week, what you do with them in that hour isn't nearly as important as the other 23 hours of that day and however many other hours are in the week. That stuff that they do on themselves is more important. So we're here just to facilitate. Hopefully we can here to help you feel better and more confident. Make things maybe provide a little temporary analgesia to show you that you're not, hopefully show that they're not as broken as they might think they are, and just give them strategies to help self-manage. And I think that's really, really important. I think that as therapists, we should all be trying to do that all the time.
Yeah, I love that.
So one of the bits I really wanted to steer towards then, at a point in this chat, is something that I know all of the rest of us have definitely suffered from, and I probably still do suffer from. But it's partly to do with Dunning-Kruger, partly to do with the fact that you what you were talking about earlier about you wanted to go off and read everything, and you just wanted to know, you needed to know. And one of the things I'm beginning to learn myself as I dive deeper and deeper into studies is that you begin to learn more and more about less and less, and actually you don't even learn more and more about less and less because you realize how little you know, which is all terrifying. But there is obviously a point in almost every evidence-based therapist's life that they go, you know what, this is bloody fantastic, this pain science stuff. And the first client that comes through the door just gets blah, 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 blah.
Yeah.
Which is my way of saying, as I think from your words, you vomit pain science at them.
Yeah.
So what do you say to therapists to help sort of maybe ward them against doing something like that? Or, you know, what mistakes can people learn from that you've made?
Oh man, lots of mistakes. I've probably, I mean, people have asked me this before, you know, how did you just get into this stuff? I was like, because I made a lot of mistakes. And what I always tell my kids is I'm like, these are learning moments when we make mistakes. These aren't mistakes. They're learning opportunities or learning moments. So my advice would be shut up. Like the vomiting pain science effect is real. You know, we have all this information. We feel everybody needs to know it. And I think that when I first started getting into this stuff, I just wanted to tell all my patients everything that I knew and basically made them feel like their experience was not real. They basically felt that they were making it up, and that everything that had been done, or everything that we'd been doing for the previous 5 or 6 years was useless. That's kind of how it came across. So when I realized that maybe I should just shut up and just drop little bits of seeds of information if the patient wants it. And what I've found is that somebody will come in and say they've got neck pain, and this is something that has bugged them off and on for years, but they're still playing rugby and they're still playing their kids and they're working full time and they're living their life, but they come in periodically because they've got a neck issue that maybe I see them 2 or 3 times a year. And they have a very biomechanical view of that neck. I don't say anything.
Yeah.
Unless they really are interested. So I just, because it's not worth it, because they're functioning. It's the people that come in that are the chronic pain patient that is suffering, that has seen every therapist, has seen every physician, every specialist. Those are the ones, and they have oftentimes very terrible ideas that were put in their heads, usually by other therapists or other professionals, and they're suffering. Those are the ones there. Well, I will probably not say anything the first visit or two, but I may ask them if they want a different explanation, or if they want to know, well, maybe it's not this, maybe it's this instead. Think about that. How does that make you feel? And then if they are interested, then we can start to have more of a conversation with them about it. Because it's easy just to throw people off by, I think, giving them information overload.
Yeah, so I'm interested then, because this is something that comes up a lot with therapists. So what do you say to people who are after an explanation for their pain? So they do come in and they say to you, you know, why is this happening to me? I've had this back pain for years, and maybe they have got those kind of biomechanical beliefs, but they're actually asking you what's causing this pain. How do you then kind of approach that without getting totally overwhelming them or making them feel like it's all in their head?
The first thing I do is I will always ask them what they think, because everyone's going to have their own idea, and they may say something along the lines of, like, I'm sure you guys have this before, well, that's why I'm asking you.
Yeah.
Well, I know, but I said I want to hear just tell me why you think. And it's usually a mechanical thing, like a disc or a facet, or they have arthritis or something. There's usually some. And then once they say that, and then maybe they've had a bunch of imaging done, right? And they've had a bunch of testing done. In those cases, I will often, the words I often use, I'll usually say things that I don't really know, because pain is confusing, and pain involves a lot of different things. What I usually will say is I'll say, I can almost guarantee that the cause of your back pain for 4 years is not specific to, say, your disc. It might be part of the overall puzzle, because I don't want to say no, because they're whole. I might say it might be part of it. It might be part of it, but it's probably a small part of it. It might be, there's probably a lot of other things going on. And then that opens up a discussion about, lifestyle factors, general health and well-being, exercise, stressors, these kind of things. So usually what I'll say, ask them what they think, ask them if they want my opinion. And then I will just usually say something simple that, well, pain's confusing. Pain's pretty difficult to understand. But usually what happens when we have pain for this long time is your body is very, very protective in that area. Obviously the structures and the tissues in there are very sensitive, but we know that the area is probably not broken. But we can probably work together to help that area feel more comfortable, more mobile, less sensitive, less protective. And then usually over a series of visits, we'll kind of drop a few more seeds of information there. And it usually works pretty well if the person is looking for answers, not looking for fixes. If they're looking for a fix, it can be a little more difficult because they just want to lie on the table and have you, squash their trigger points or something crazy.
But there's sometimes, though, if you use the symptom modification as massage or whatever technique you do, that in itself might help build therapeutic alliance, which then that come with trust. And then what you say can make, and sometimes I find quite useful for those, let's say subgroup of people which are quite dependent, they have very unhelpful beliefs, and they recognize themselves through those, they identify themselves into those unhelpful beliefs. I do a questionnaire after a couple of treatments. So I do a questionnaire before, but I give them another pain questionnaire just because I want them to start themselves putting a questionnaire where I say, what's your mood? What's your stress level? What is, general profiling of the client and how the pain is affecting them, because I want them to start making for them to think themselves between, okay, that pain that I have in my back and the stress, the pain that I have in my back and that sleep pattern, the pain I have in my back and my mood. So just for them filling a questionnaire by themselves, sometimes I find it personally useful because you're already starting making them think.
And I like the comment you made there, Anne-Marie, too, about building the therapeutic alliance. And that's where my next point was going to be, is that if we can get them on side a little bit and we can modify their symptoms through touch and maybe through some active or passive movements, and then we can start having that conversation that it's more about nervous system sensitivity and more about that rather than a structural problem, because we know we can change the nervous system sensation relatively quickly, and we can't change your structures and your tissues through a 45 or 60-minute treatment. So I find that works really well. And to build on what you said, is you use your touch, build that relationship, and then you can start to give them a different story. And I found that once people buy in, once they accept or they understand that it's more about sensitivity and protection and the nervous system and stressors and all these other psychosocial things outside of the bio stuff, that works really well at getting people to become less disabled with their pain. Maybe they still have pain, but they become less disabled from it.
You used a beautiful word before, suffering. They suffer less.
Yeah. So I think that's really important for us as therapists to understand, is that the pain elimination isn't always an easy goal.
Yeah.
But if we can help function and suffer less, then the pain becomes something that they can manage a bit better. That's my experience. That's how I understand from what the science that I've read too.
Eric, as an educator, what do you think is the correlation between people understanding pain science, coming to your courses or to other courses, and actually putting them into clinical practice? Do you think that there is still a little bit of a gap between I know I understand pain, or some of pain science, I understand it, and I know how to apply it?
Yeah, that's a huge thing, and I see it all the time. And I think we were chatting before. This is the pain science, but, or the biopsychosocial, but, it's those kind of people that they have an idea of it, but then they look at, so we use the term pain science. They look at, they understand, they think they understand the pain science, but then what a lot of people do is they look at how to apply pain science into their preferred modality or their preferred narrative. They're like, okay, well, I'm a structural integrationist therapist, but I understand pain. So how can I apply pain science into being a structural integrationist where I'm still focusing on like alignment and tissue length relationships, all that kind of stuff? And that's a big thing that I see a lot of. And I can see by the smile on your face that you see that you guys see that all the time too. And that's hard, I think, because pain science doesn't give us any easy answers. It actually creates a lot more questions. So I think the application of pain science to what you do in practice it is lost on a lot of people. And that's what the courses I do is I really try, and hopefully every time I do a course, I get less terrible at it. I've been doing them for a lot of years, and I feel that everyone I do, I get better and better and better at trying to deliver that message or those key messages of, pain science is actually empowering. It's actually encouraging. If we understand why people hurt, and we understand it's not always specifically because of some pathoanatomical structural issue that we need to fix, and it's bigger than that, then it provides us more options and more opportunities. And so we kind of go from that, and I spend not a lot of time, depending on the course, I spend time on kind of just how do we apply this information to what we already do?
Yeah.
Right. How do we apply this information to our practice without completely reinventing the wheel, but maybe just making a better wheel?
Do you think
Being less wrong.
Being less wrong.
Yeah. Do you think things are improving? I mean, you say for a long time you felt like it was just yourself out on your own, and we chatted last time about how nice it is that we've connected, and that there's this nice little network knocking around now of people that have the same kind of ideas. Do you think we're going in the right direction as a profession?
Yes, very much. It's slow, it's glacial, it's not very fast, but it is moving. And if I think back to say 2000, I think it was 2014 or 13, I read Explain Pain, and the San Diego Pain Summit was 2015. If I think back to then, so 5-6 years ago now, it was like there was nobody in where I lived. Like I was the only one in Vancouver, which is the next biggest city, which is not too far from here. I met a couple colleagues at San Diego that from there,
okay.
And we connected. I was like, oh, there's a little group of people in Vancouver as well. And then kind of initially, kind of the group of us, we started bringing other people into our groups and started, basically started to grow and started to talk, and like let's bring other people on board. Let's ask questions of people. Let's get together in groups of us together and try to try and make sense of this research. And so it started small, but then now I'm seeing more chatter on social media, and I'm seing more conferences and courses outside of just our little bubble here, but like you guys in the UK, and then in the US, I know a bunch of people there that are doing similar stuff. It's not reached that far everywhere, but it feels like there's little pockets all over the place. I'm hoping those little pockets will grow.
As the new education changes and is changing, the new therapist will be the lucky one. It's how to change, how to cross the bridge for those that have been in practice for 15, 20 years.
Yeah.
That is the hardest.
Very hard.
And to a certain extent, I think, Becky and I are in a similar boat there, where when we came into the industry, we were fortunate enough to be being taught within what is
BPS,
BPS model effectively. And so the information we were receiving, whilst contrary perhaps to our beliefs as previous recipients of massage therapy, if you will, I used to see a massage therapist because they flushed my toxins, etc. But actually to learn in that environment means I haven't necessarily had to go through that real cognitive dissonance. And I'm very passionate about not necessarily bashing therapists over the head for not having all of that skill set already, but definitely bashing education over the head for not keeping up and making sure what they're providing is of a suitable level.
Yeah, I agree. Oh, sorry, Matt. Keep going. No, keep going.
No, carry on.
I was gonna say, I think the biggest, I like that you said that, because I think it's easy for us to start blaming therapists for being uninformed. But if they haven't been informed, or if they are not familiar with the material, then how can we blame them for not knowing? I think the only time we can blame therapists is when they've been presented with this material and they refuse to try and learn more or ask questions to learn more. But I definitely think the biggest, and this is where I'm 100% on board with this, is because this was actually part of my thesis, was on the barriers and facilitators for research evidence in massage therapy practice. And the biggest thing that came up was people weren't introduced to it into school.
Yeah.
And if you look at physiotherapy, chiropractic, any other medical profession, any other allied health profession, if you're not introduced to this kind of stuff in school, it makes it much more difficult for it to unlearn.
Yeah,
absolutely.
Which is hard. So I think the schools have a huge responsibility, and I think the schools have to take that on themselves to at least introduce these concepts to students.
We had a really interesting chat with a colleague the other day, actually, that hadn't really occurred to me before. But he was saying that in his experience, massage training, soft tissue therapy training, and so on, didn't encourage people to question things. So you kind of came out your course having been told everything as fact, and never being encouraged to challenge your tutors, to challenge what you were being taught, and to also be aware that you weren't going to come out of this with all the answers. You know, these courses were sold as, you'll have all the answers, you'll be able to fix people's pain, this is what's going on, you know, whereas and I didn't go to university, but what I know from people that have, and chatting to Matt and things, is like what you're taught in that environment all the way through is to question everything. So suddenly you come out into the big bad world as a therapist and people start questioning you, and you're like, oh God, like what's going on? Why is everybody questioning what I'm doing? Because you just haven't been exposed to that thought process in your massage training. Which I think, you know, that was when he made that point, it was a bit of a light bulb moment for me. I was like, well, yeah, God, of course no one questions it, because they're not taught to question it.
No. And I think the thing is, what happens too is you have a lot of the massage training, or the vast majority of it, I could guarantee anywhere in the world, it's a belief-based system. And it's like you learned this when you were a student, then you become a teacher and you just pass on that knowledge. It's like this oral history kind of stuff is what happens. And so so if you were never taught to question it, and then you go and teach, then you're going to teach the students how not to question. So it just kind of feeds itself. And yeah,
absolutely. And you know, building on the point Becky made there about the fact that courses are often sold, particularly in vocational studies, you know, non-university based studies, they are generally sold as, this is a package at the end of which you will come out and you will be a qualified X, which brings with it the assumption that therefore you will know everything you need to know. And yet with massage therapy, you know, you talk about continuous education. In the UK we call it CPD, continuous professional development. And so there is an expectation that therapists will go out and continue to learn. The problem is that most therapists have been taught that to continue learning essentially means to add more modalities to their roster. And the courses that then fulfill that continuous education requirement are also not teaching therapists BPS model, evidence-based practice, to question what's going on. And so frankly, to dive into the evidence itself, firstly, requires an awareness that it exists, which I don't think is communicated particularly well. Secondly, might require understanding or at least knowing the names of certain people to look for, to sort of, you know, you need a seed. You know, whenever you pick up a research paper and you find a reference in it, you then look for that reference and see what they've who they've referred to before, but you need that starting point. And I think unless you're thrown, like yourself, a starting point, Explain Pain, Lorimer Moseley and Butler, and go, okay, so who did, where their work come from, what have they built on, and follow that. I think therapists run the risk of just being in this continual bubble, and the schools, to a certain extent, why would you market your course as this is the beginning? When you finish this, you have started.
Yeah.
It's super tricky. And I think, talking of marketing, one of the things I'd love to just to pick your brains on actually is from your therapist side. So now with your therapist hat on as opposed to your educator hat on, how do you market yourself in an evidence-based way, in a way that feels morally right to you, but against a backdrop of, particularly like you said, when to begin with, 5,600 other therapists sort of vaguely locally, you were the only one who was really thinking in an evidence-based way, in a BPS kind of way. And marketing for massages often come to me and I'll release the tension, I'll flush your toxins, how do you market yourself, or how should how could a massage therapist market themselves in such a way that they can make a living, but they're not marketing bullshit either?
Yeah, and that's a tough one because shit sells, right?
Yeah.
People want to buy shiny shit. I know, it's crazy. Yeah. So for me, the first thing I did is I just removed the list of any modality or content course I had from my kind of about me page, or from my page on my website for my clinic, because I didn't want to. I was like, I don't want to identify with fascia. I don't want to identify with structure. I just eliminated all that stuff. And so I think I don't even know what I'd have on there now on my clinic website. But I think it just basically says something along the lines of, evidence-based practice or evidence-informed treatment decisions to help you in your with pain or suffering, and something along the lines of, treatments consist of, hands-on stuff, movement, education, and exercise. So I basically just kind of, here's a general idea. And my thoughts is that if someone comes to the website and they look at the web, I mean, as it is now, like, because I own my clinic, we've been there for a long time. We have a lot of therapists there, and they're all like evidence-based therapists. So I don't have to challenge other people's ideas from other therapists in the clinic, because we're all speaking the same language, which is brilliant. I mean, I think we're lucky that not a lot of people have that.
Yeah.
Like we even have like 2 chiropractors who are like evidence-based chiropractors who, which is unusual, right? It's like they're like physiotherapists that just, specialize in spinal stuff. But anyway, so I don't have to worry about setting myself out from those people. But for other people, if you're in a clinic and say there's 5 or 6 other therapists, and you have something on your page, your kind of about me page, that's completely different from everybody else in your clinic, that sells. Well, I want to see this person. They're talking about, evidence-based, and they're talking about, their treatments focus on, addressing the nervous system, and how that influences pain and disability. And everyone else has got, I've got ART, and I've got level 3 fascia, and I've got this and this and this, and you have something that's completely different. That actually works really well. Because when I first started, I get people all the time like, I want your website and I want to know what you're about because it was so different. So I think it's okay to be different.
Again, that kind of it starts that conversation, doesn't it? If it's they almost phone you up and go, well, what is it you actually do, and how are you going to help me, and that in itself kind of opens a conversation, which is nice.
Yeah, that's what I found anyway, early days. It's been a long time since I've had to do with that anymore, because our clinic itself kind of we're fortunate we kind of have that reputation that people don't come to the clinic with this, like they kind of know what to expect from us.
Yeah.
And what we do is probably not different than anybody, really. It's just maybe our management or ideas or ideals behind what we do is might be a little bit different.
That seems a really good point, a really good time perhaps to sort of summarize. And I think to kind of summarize our chat today, we'll kind of shoehorn it into our normal feature of theory to practice, which is, we've talked a lot of theory, but you brought out maybe 4 or 5 key points about how to apply evidence-based practice biopsychosocial model in clinic. So do you mind just quickly, Eric, just summarizing those points for us again, that you'd like people to go home with?
Yeah. So yeah, I think the key stuff, and this is stuff I always focus on in my courses, and I'd say obviously easy just to say words right now, but like how do we use those words in practice is more than just a 1 minute thing, which is fine. But things like, so obviously first thing is hold space for the patient. So listen, focus, be patient centered. That's key. Validation. So always validate their experience, because if they're in pain and they're suffering, then who are we to judge? We just have to accept that what they're saying is their experience. So I think that's a big thing, is understanding that pain is a unique experience to the individual that's in front of you. I think a key thing too is that when we are doing any assessments or any hands-on treatments with the people, that those should always be used to infer strength or resiliency or confidence or reassurance. It should never be to look for fault and find something that's wrong. It should be, let's reassure that everything is good, because we know that probably 99.5% of the people that come to see us are what we would be I think Peter Sullivan used the term the worried well. Yeah. Like they're probably not people that need quick medical attention. So that's key. So all about reassure. And the TPN, so our hands-on stuff, should be touch them nicely, touch them in a way that feels good. Now that could be a little heavier handed, that could be a little bit lighter handed, it could be depending on whatever works for that patient and for you. And the last thing too is use the conversation we had, use your reassurance and your education to allow them, we're not going to say give permission, but we're going to allow them to make decisions that they can get back to doing the things that are important to them.
Fantastic. And so in sort of wrapping up today, where can people find you? What are you up to next?
Yeah, so my website is my name, so ericpurves.com. I've got blogs on there. I've got a listing of all my in-person and online courses that I'm teaching. Next thing for me is actually business-wise, or from my education aspect, is I'm actually launching a membership group specific for manual massage therapists. So it's going to be should be quite affordable, but it'll be a monthly membership group. It's going to be launched in January. And what we're going to do with that is it's basically just going to be a way for a community of like-minded therapists to support and learn together. And so we would, formats like this, we would have monthly discussions with people on specific topics. I'm going to bring in, I have a list of other educators or other people that are doing wonderful things in our profession, and kind of highlight them. And then we'll do monthly research reviews as well. So that's my next big thing I'm doing is the membership. And so hopefully, I've never done one before, so I'm starting to make it cheap, but hopefully it'll pay off. And I really feel that we need a community of people to work and learn together, because I don't want to learn in isolation, and I learn from every conversation I've ever had with other therapists, like this one today. I found valuable for me as well. So that's that. And then I'm starting my teaching course. I'll start my next courses teaching in February. So I'm going to do a course at the beginning of February, and then I've got a whole list of ones for next year, and those are all on my website.
And we got the one on the 6th of March for our UK.
Yes, I was just going to say, yeah.
Clinical applications of pain science for massage therapists.
Yeah.
So 6th of March, we'll put the link on the post.
Yeah. Yep. And that's the one I'm excited about most next year.
Good. Okay, right answer.
No, I'm really looking forward to that, guys. And so please, I hope that we can get some people to attend and make it worthwhile for everybody.
Absolutely. No, we're really looking forward to having you talk some more and well, for you to take the lead. It'd be fantastic.
I can talk forever, so otherwise.
Me too. I quite like. I wanted to to read a quote of Eric. I've been following Eric for many years, and he's on the first slides of every course we teach on the first day. And so I just want to read the quote for everybody there. And he says, "We do not need to make up stories to explain what we're doing. Touch is therapeutic. Massage and movement are analgesic. These effects occur because of our interaction with another person's nervous system." That for me just encompasses everything. So thank you.
Oh,
That would have been a really short podcast if you'd have started with that.
That's it. Good night.
bye. See you later. Yeah, no, that's thanks, Henry. That was what I think. That was probably from one of the first blogs I wrote.
Oh,
I think.
I am pretty certain it's 2014.
Yeah,
I'm pretty sure. Yeah.
That's great. That's when I was still trying to figure out what the hell was going on.
Yeah, very
I'm
good.
still trying to figure out what the hell was going on. I just have.
We're all still trying to figure it out.
Yeah, which is great.
Well, we're really pleased you have a little bit more of a clue and are able to talk about it so eloquently.
Oh, well, thank you guys. Yeah, thanks, Matt. Appreciate that.
Well, thank you very much for joining us today, Eric. It's been fantastic.
Yeah.
And we will look forward to seeing you ourselves again in March, hopefully with a whole bunch of other people willing to learn as well. And thanks once again.
Okay.
Thank
Thanks,
you,
guys.
Eric.
Appreciate
Bye.
it. Bye-bye.
And that, ladies and gents and fellow therapists, is why we love Eric Purves. There's just something about his approach and the passion and compassion that he manages to combine to provide the context in which an evidence-based manual therapist can really work well within a patient or client's healthcare journey that I think, well, it just ticks all of my biases, really. And it's okay to have biases as long as you recognize them, so I'm told. Anyway, one thing I did want to just quickly correct is Anna mentioned Eric is coming and teaching his clinical applications of pain science course for us, but it is on the 9th of March, not the 6th of March. That's the 9th of March, 2021, Eric Purves. Tickets are available on Eventbrite. I'll try and leave a link in the description below. Otherwise, please go to Eventbrite or Google Eric Purves Eventbrite and it should pop up. In the meantime, thank you so much for joining us once again. I hope this has helped kickstart your 2021. All the best of luck for this first part of the month, and we will be back with you in a couple of weeks' time. Until then, take care.